Hello and welcome to what, and Why. This is a series dedicated to discussing vital publications in the field of HIV while also shining a light on the vital contributions of women clinician researchers. I'm your host, Toyin Nwafo. I'm an infectious disease physician, clinician researcher. I'm a pharma executive and a passionate HIV advocate. And in this series, really, the goal is to break down those silos and move beyond the firewalls that often separate us from the authors of this important research work and the people who are reading this research and can take it into practice. So what we'll do is we'll delve into the unmet needs that prompted their work, explore what was done, examine their findings, and really just demystify research and talk about why this is really important. So what, and why? And so today I'm excited to be joined by my dear friend and colleague, Dr. Brenice Duroseau, who will introduce herself. And she will share her expertise and insights on an important publication, one of my all-time favorites, on sexual health histories and U.S. Healthcare providers. So my guest, Dr. Duroseau, please introduce yourself.
Thank you so much. I'm so excited for this episode and so excited for this work. It's very much needed. So my name's Dr. Brenice Duroseau. I am a newly minted PhD. I just finished my PhD at Johns Hopkins University School of Nursing. My background is in infectious disease and addiction medicine. As a nurse practitioner. Prior to that, I worked on labor and delivery for many, many years. So having women central to my clinical experience has been really the backbone of a lot of the work and the passion that I bring into my research areas of interest. I started off with a bachelor's in psychology degree. I did a little bit of bench science prior to moving on into nursing. And nursing as a profession is very near and dear to me. So even as a now nurse scientist, bringing in like that nursing perspective, my training as a nurse is integral to like all the work that I do. So I'm so excited to be here to talk about this work.
I am super excited, and I'm sure our viewers are. And thank you for sharing your expertise and your passion and your lived and passionate experience into this research. So we're going to dive into it. A lot of us who publish talk about background, methods, results, and conclusions. Well, that's what this is. What, and why. So, I'd like to start off with, what is this article? Could you tell us the title of this article and what was the unmet need that made you say this work needed to be done?
Yeah, so myself and my wonderful colleague, and in some ways a mentor, Dr. Reagan Johnson, we were working on a different paper. And in that experience, we kept talking about, okay, how are these assessments done when it comes to sexual reproductive health? What are some of the limitations as clinicians when we're having these conversations? What are some of the things we see that we're missing? And then also as Black women who are central to many of the, disparities that we hear about. Black women are most at risk for this, the highest numbers in all these things. We were having this discussion around how can we capture these women in our assessments and to also have help clinicians do this work as well, because women are falling through the gaps. So that's how we came up with this 8-piece framework. And it was really, the goal of it was to bring assessments and sexual history taking into the 21st century. A lot of what has been done, although it was groundbreaking at the time, was outdated. It was before dating apps, before digital intimacy, before rapid misinformation through social media being able to be infused into households at unprecedented unprecedented speed. So we needed to do something to bring these assessments into real time with real people in a more meaningful way.
Thank you so much, because your article, this a novel 8 P's framework for addressing complexities in sexual health histories for U.S. healthcare providers, So important because many of us and most clinicians may know, not all, about the 5 P's, right? About how to take a sexual health history. But you told us, a lot of that was good. It got us to where we needed to be then. But moving forward in the complexity of what is the reality and why this work is really important. So, and in the show notes, we'll definitely have a link to the full article. So you've kind of talked to us about what the unmet need was. So what did you do?
So we added two more P's to the framework. So the six P's that was added on. So the five P's was through the CDC, and then there was the six P that added plus, which was pleasure.
For
And
sure.
So that was like integral. A lot of the work, like with Dr. Shamika Thorpe, for example, she focuses on pleasure a lot. So we're
For
not
sure.
always addressing sexual health from a deficit standpoint because you don't want, to stigmatize people. You don't want to take away the pleasurable aspect of sex and health and wellness. So what Dr. Johnson and I did, we added two extra P's, which are perspectives and proximity. So that takes into consideration geobehavioral vulnerabilities. So where you live, where you play, where you're dating, and that's variable with dating apps. I could be here in Maryland and matching with someone in California. But though it does, so when we talk to patients and have these conversations, it does not take that into consideration. And even as a woman myself, if where I'm dating, if I don't really understand the climate, I don't understand the prevalence of different things in that environment, I don't have an accurate assessment of my vulnerabilities in order to make different certain decisions, whether it's prep, whether it's, screening, depending on your climate, those decisions may have higher priorities. Although everyone should be doing these things, but I think when it comes to people's perspectives of things, having an accurate understanding of where you're at, what you're navigating is also important. So that's why we added those two P's for providers to be able to one understand what do patients know. We see with social media, there's a lot of misinformation. So 9 times out of 10, sometimes when I'm having conversation, someone will say something. I'm like, that's actually not accurate. But if I didn't interrogate or ask the right questions, I'm missing those moments to recognize like, oh, we're not even talking about the same things, or you don't even really understand that prep is actually for you as a cisgender Black woman. It's not just for
Wow.
MSM population. So perspectives was another point that was very important on top of the proximity, knowing where people are navigating. And even as clinicians, some clinicians have no idea about like the ending the HIV epidemic jurisdictions, and they're working in Baltimore but have no idea about those prevalence and
Okay.
the epi data.
Wow. I mean, you can tell how important, and you know how important this work is. And for someone who may be joining and just really trying to get into this conversation, we talked about these two new P's you added, but do you mind just kind of highlighting what those other first 6 P's were, just what they were?
Yeah, so there is pregnancy intention, past history of an STI. There is partners, so who you are actually engaging in sexual activity with. I have to always count them so I don't miss something. So there's the partners, and there's also like different vulnerabilities as far as like IV drug usage or drug use while engaging in sexual activity. And then there's protection as well. So like if people are using condoms, not using condoms, and then there's the plus, like I've mentioned, which includes pleasure and also like your identity, like your sexuality. So making sure like people are affirmed around their sexuality, their sexual identity.
Wow, thank you so much. And there's so much to unpack there. And
Mhm.
so you kind of talked through the what was the unmet need a lot, and what you did by adding these two really important perspectives and proximity into that conversation. And so, what did you find, and kind of why should we care if we're trying to move towards ending the epidemic as clinicians, as community, with this new framework?
Yeah, so we just had a session with Health HIV with their Effie Berry institute where we were able to present to a group of people, and just through the questions in that, like, what are people doing, what are some of the barriers as far as like a clinician to be able to do this history. And a lot of you, we were surprised to find that time wasn't one of the top ones. It was still a point of consideration, because we always know as clinicians we don't have time to do all the things. What are the priorities? So sometimes it was just like, okay, what do I ask? How do I ask these questions? How do I ask these questions without offending somebody or without making it seem like I'm making an assumption? So how you ask the question was important. Um, Trying to understand, where does this fit into my schedule and my workflow was another thing. So when we first came out with this, we had conversations around, okay, how is this going to be received by providers? Is this going to be one other thing that we're adding to people's checklist, two other things on top of already, we aren't even covering all the
Right.
six P's to begin with? So how do we sell this from like even like a marketing standpoint when we're trying to drive change? And it's important to note, you're not going to get all these eight P's in one conversation. A lot of what we do with patients is about relationship building. So that first
Relationship.
visit, you might not get this information. It's about building that relationship and also leveraging your staff who may also have that relationship. So, what's the MA asking, and what information are they getting while they're doing a blood pressure? What about the nurse? What is she tapping into? And you could use the EMR, the electric monitoring record, to build a story over time. And we are storytellers. So using that over time across the health system. And if everyone has an all hands on deck approach, we will ultimately be able to get that full picture of someone's sexual health history and what their needs are. So I say all that to say, like, although people felt like, it could potentially be overwhelming, I think when we presented it that way, it creates more of a team-based approach, and I think people are more receptive. And also having examples in the paper of how to ask these questions, I think is helpful too, because it's all a learning and like your style, and
Yeah.
every patient's going to be different.
You bring up such critical points, right? About the importance of trust and relationships, storytelling, modeling best practices, even with the paper, which is why it was so impactful. And that's the thing, is being able to, as a clinician researcher, you are able to figure out just having the data out there was not going to be enough. We need to engage people and see how it would fit into their work stream. And that's why it really is important to amplify the work of clinician researchers, because you've been on that end. You know what it means to be in the clinic with the competing time constraints, but also how do you integrate things to drive change. So I love that. So again, this is like unmet need. What did we do? How are we making sure that it can be embedded into practice? And so why should we care?
Yeah, so we constantly talk about like health inequities. What are we doing to address these health inequities? But we don't focus a lot on systems, because systems are the major drivers to a lot of these inequities. We focus around patients changing their behaviors, patient uptaking PrEP, patients using condoms, but we don't talk about providers. What are we doing? What are the systems even allowing us to do within our capacity? Where are the restrictions at? So why do we care is that we're doing outdated medicine. We're creating gaps, and we're allowing people to fall through the gaps. And if we say we want to end the HIV epidemic, if that's still a national agenda, then we have to do something different. So if we care about the work that we're doing, we care about the outcomes we've already standardized to say, we need to get into the 21st century. And the 21st century requires us to have an accurate perception of per, um, proximity to vulnerabilities, and an accurate perception of what our patients' perceptions are, understanding misinformation, understanding distrust, understanding those things, and actually building relationships with the communities that we serve.
Oof, that was phenomenal. So again, thank you so much for sharing this framework with us, the publication. I know it's going to do a lot of great things in terms of how clinicians practice and move us closer to ending the epidemic. So I asked this of all my guests, two questions. One, what keeps you going, right, as a clinician researcher and publishing? And any advice, one piece of advice to someone who's just starting in this, trying to publish HIV research. So, what keeps you going, and a piece of advice for someone who's coming behind you?
Yeah, well, what keeps me going is I'm a woman of faith. I'm a Christian, so God first and foremost, because some days, especially with current political climate and tensions, it's tough. So I think being grounded in my faith is one, and then also having a community of women, especially Black women, behind me, alongside me, in front of me to show me one, what's possible alongside me to show me that there's a sisterhood here, there's community, we're doing this work. And then the women coming up behind me, knowing that what I do today and the gaps that I stand in right now is going to either create or close off opportunities for other women. So being intentional about that privilege and the gaps and the spaces that I get to be in. So those are the things that keeps me going. And for advice with people coming behind, get mentorship, find community. And we always talk about what is the strategy and all these things. And with academia, there's very much a hidden curriculum. You're Until you get in community with other people who have been successful at doing the things you want to do, it's harder for you to figure that out. So having that mentorship, and not just mentorship, sponsorship as well. People who are going to put your name into spaces, who are going to vouch for you, who are going to leverage their privilege and their proximity to your benefit, versus mentorship, who may not always do that and fill in those gaps. So identifying those people and reaching out early is going to be beneficial for you, and also being a good steward of community, not taking advantage of the people near to you and the people you say you want to impact. Have those relationships with them early on. I think that's important to leverage and to be genuine.
Wow. Thank you so much. And, a lot of things that you said really struck me. And I just love what you talked about, the intentionality and how what you're doing either creates or closes up opportunities. And really, in that gap, making sure that you're paying it forward, creating opportunities, and the advice to people coming along, and mentorship and sponsorship. So, this closes out this episode of what, and why. Thank you so much, Dr. Duroseau, for really walking us through that. The full article, the link to the article, and Dr. Duroseau's work and some of the other work she's done and published will be in the show notes. Really excited that we're able to have this conversation. Thank you for the important work you do. This is just one of your many publications, and I'm looking forward to just seeing the impact of this in practice and how we do a sexual health history taking. So thank you for joining us, and looking forward to more conversations with you. Thank you.
Thank you so much for having me.